Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much for everyone attending this live webinar this evening. And we are very pleased to have 3 of them speak. And I'm very proud to share moderating this session with Dr. Haitham Khalifa and Dr. Wissam Ibrahim. Both of them are well known to the faculties and the fellows of our program, Point of Care Ultrasonography in Acute Care Settings in the Advanced Pathway. And today is the live webinar number 3 in the Advanced Module of Emergency section. And this is the week number 15. And as just to remind all our fellows that we have 24 weeks, week number 24 will be for the exit exam. This batch of 4 weeks, every 4 weeks we meet for live webinar. This 4 weeks, the previous one, were very interesting topics of VTE, pulmonary embolism, ocular ultrasound, as well as OB.GYN needed point of care ultrasound. So for the fellows, please, if you have any question, don't hesitate to write it in the Q&A section and Zoom here in the bottom, or even the chat section, and we'll direct the question to faculties. Again, if you have any cases for discussion, you may raise it for discussion. Without any further delay, let me give the mic to Dr. Haitham Khalifa to introduce our first speaker of tonight. Thank you, Dr. Haitham.
Thank you, Dr. Ashraf. We are happy that you are with us, and I am with great faculty. Today is a very interesting day. We will discuss hot topics, some areas that we don't know about a lot about in the POCUS in the emergency department, but it has a great value as you will know today. We will start with our enthusiastic instructor and faculty member, Dr. Muhammad Nasri. He is a lecturer of emergency medicine from Tanta University, and he's working as a consultant of emergency in Riyadh. He is instructor in different international courses of resuscitation and point of care ultrasound. He will give us interactive cases in the airway and the neurological focus in emergency department. Please be ready. He has some interaction and it will be inshallah great talk. After the talk, if anyone has any question, please write in Q&A and we'll ask Dr. Muhammad directly. Dr. Muhammad, the floor is yours. You can share your slide now and you can start.
Okay, thank you very much. Thank you, Dr. Haytham and Dr. Wissam, and for sure, Dr. Ashraf, and thank you for our colleagues here today. My name is Muhammad Nasruddin. I'm a lecturer and consultant of emergency medicine, and over the next few minutes, without any delay, I'm going to discuss two clinical-based scenarios discussing the utility of the point-of-care ultrasound in two cases. The first one is sudden vision loss, and let's discuss how could ocular point-of-care ultrasound save sight or save vision. And the second one will be a patient with severe traumatic brain injury. Let's try to figure out if point-of-care ultrasound can detect the pathology even before being detected by computed tomography. So it's meant to be an interactive session. So I would encourage everyone to have like a second device, like second mobile or tablet or whatever, because we are going to use Slido polling during this interaction session, trying to explore your opinion about certain issues. So let's jump for the first case. We have 65-year-old male presenting with sudden painless vision of loss in the right eye that have been started 2 hours back. So let's dig deeper. If you're asking about the patient history, so he has a painless vision loss during 2 hours back. He has history of high myop and diabetes mellitus. In examining the visual acuity, he has only hand movement only perception on the right side, while normal visual acuity on the other side. On external examination, pupils are regular, rounded, reactive equally, and no external eye abnormalities. So let's start with the first question. So by joining that slide on this session number, or scanning the QR code on the screen, could you please tell me what you are thinking about? What could be the differential diagnosis for condition that make your patient have similar complaint, sudden painless vision loss? So let's wait for a couple of minutes before going for the answers. So central retinal vein occlusion, for sure, this is one of the cause. Retinal detachment, yes. Again, retinal detachment is one of the possible differential diagnosis. So yes, as you mentioned, keeping in consideration that we have an old age with diabetic patients, so retinal detachment is also one of the main differential diagnosis. If you have a rapid look over the possible or potential causes, it can be grouped under either retinal causes or posterior segment cause like retinal detachment, vitreous detachment, or vitreous hemorrhage, vascular causes like central retinal artery or central retinal vein occlusion, and for sure other neurological causes like stroke condition, occipital stroke, or other migraine or a condition. That will be added to other optic nerve and other ocular lens dislocation, endophthalmitis, or ocular trauma, post-traumatic event. So let's dig deeper in our patient. He has a preceding history of flashes of lights, new onset floaters, and he's like describing a keratin covering the visual field. So as we can see here, the first thing you are going to think of using the fundoscopy, doing fundus examination. But if you have like either physically not available fundoscopy or functionally not available because you are not a little bit confident in using the fundoscope for doing fundus examination, what's your next diagnostic modality? And I think this is will be one of the most important points that point of care ultrasound could handle the issue. So let's go rapidly through the mechanism, or sorry, the image scanning technique for getting ocular ultrasound. For sure, we are going to use our superficial or high frequency linear probe. The patient will be supine with eye closed, putting transparent dressing over the eyes with liberal amount of gel, avoiding any direct pressure over the globe, and trying to scan the globe in both dimension, transverse, longitudinal, with dynamic eye movement. And for sure, if we have any suspicion of rupture globe, this examination is going to be forbidden. So let's have a rapid look over the normal sonographic anatomy with ocular ultrasound. This is the anterior chamber. This is for sure the eyelid, and then the cornea, anterior chamber with the aqueous inside, iris, and this is the lens. And posteriorly, this will be the vitreous chamber, and the most caudal layer will be the retina with the optic nerve emerging from behind. Back to our patient. So we used our probe, and this is the image that we find. This is the eye globe. This is the cornea in front, maybe a little bit not clearly evident. And this is the posterior segment at the back. And here is the optic nerve emerging from the retina. So this is the second station for our Slido. So what is the abnormality could you detect in this scan? Is it vitreous hemorrhage? Is it vitreous detachment? Is it retinal detachment? Is it orbital cellulitis? So waiting for your cooperation, your participation, and your polling. What do you think is the abnormal finding in the previous scan? I will give you a couple of minutes. You can also use the chat if you are going to, if you can't use the Slido polling, you can enter your answer in the chat. So yes, 100% true. This is a pure, straightforward case of retinal detachment. So what I'm going to discuss here, if we have any problem in the posterior segment, the differential diagnosis will be a little bit narrowed to main three conditions. The first one is the vitreous hemorrhage. And here, this is a very nice clip for vitreous hemorrhage. We can see here like echogenic material freely mobile, swirling amount in the vitreous or the posterior chamber of the eye with eye movement. And this is giving like the washing machine sign or the snow globe sign. This is will be the picture with acute hemorrhage, while in chronic cases of vitreous hemorrhage, it will appear as organized membrane that could be layering dependently in the posterior side of the globe, mimicking the second condition that we are going to discuss, which is the vitreous detachment. So for posterior vitreous detachment here, we can clearly see this very fine hyperechoic membrane crossing over the midline, crossing over the optic, sorry, this is not the midline, crossing over the optic nerve in the posterior segment of the eye, freely mobile and not attached to the optic disc. Here, this is the optic nerve and this is the optic disc. If you can see with the movement of the eye, that will be the markers for the optic nerve. So this membrane is crossing over the optic nerve in front of the optic nerve, freely mobile. And sometimes you would need to adjust your gain for better visualization. And this is characteristic of posterior vitreous detachment, which actually is less urgent and less have a better prognosis than the more scary condition, which is the retinal detachment. Back again to our patient, we can see here this is the thick hyperechoic membrane at the posterior segment of the eye. It's a little bit tethered to the optic disc, it's not moving clearly or not moving freely, and it's again not crossing over the head of the optic nerve. So this will reflect the condition of the retinal detachment. Again, it will appear as a hyperechoic membrane in the posterior side of the globe, tethered to the optic disc and extending peripherally toward the oral serrata. However, it's less mobile and thicker than appears in the posterior vitreous detachment. While if this detachment is spreading on both sides of the optic nerve, it will give us the characteristic V-shaped appearance, as we can see here, as it will remain tethered to the optic disc. And this is one of the most important points that help us to discriminate between the retinal detachment and the posterior vitreous detachment. And here we will go to another problem or another very diagnostic piece of information that we should focus on, which is the condition of the macula. The macula is the most sensitive part of the retina, and it's in the center with the central axis of the eye, and it's for sure responsible for the central vision field. So it's very important to double check if it's the macula affected or not affected with the retinal detachment. So in the macula in condition, this means our macula is still on the retina, so the detachment is not spreading to affect the macula. This is called macula on retinal detachment, which is a very emergent condition because we have to intervene immediately to save the vision and save our save our sight. While on the other side, the macula off condition with the extension, when there is an extension for the detachment to affect the macula, so the macula will be on the temporal side of the optic nerve. Optic nerve will be on the nasal side, and the macula will be on the temporal side in one axis with the center of the cornea and the lens. If the macula is affected, that will be a macula of retinal detachment with still, which is remains an urgent condition. But here the philosophy will be we should intervene urgently to restore, trying to restore the vision. So trying to differentiate between these three conditions, we have a posterior vitreous detachment and retinal detachment, and both can occur together. As vitreous detachment, one of the cause of tractional retinal detachment type. Chronic posterior vitreous detachment may become stiffer and denser, causing it to mimic the retinal detachment. And again, the same for vitreous hemorrhage. If it's long-standing, it will causing like a membrane, hyperechoic membrane layered at the posterior aspect that give you a picture similar to retinal detachment. And from here came the importance of point-of-care ultrasound, trying to differentiate between three conditions. Back to our patient. So what should be the next intervention if you are suspecting a macula on retinal detachment? For sure, the first action will be immediate ophthalmological consultation, trying to protect our eye, avoiding any further ocular pressure, eye shield if indicated, and providing analgesia and emetic, as vomiting will increase the intraocular pressure. Again, assessing for the macular status using the point-of-care ultrasound, dynamic scanning for globe to make sure either the macula is affected or not, so macula on or macula off retinal detachment. And for sure you will need a more conventional assessment of the posterior segment of the eye using formal fundus examination plus or minus optical coherence tomography to confirm and detect the extent of the retinal detachment. And that patient for sure will need an urgent or emergent intervention for definitive surgical repair. So using point-of-care ultrasound, even in the absence of fundoscopy, or if you don't have the skill of doing fundoscope, will save the sight of your patient. Just to sum up, flashes plus floaters plus curtain, this means retinal detachment until otherwise proved, in particular in patients with high-risk condition like diabetes mellitus. Ocular point-of-care ultrasound will give you a clue for structural identification of retinal detachment and will help you to differentiate between this condition and others similar like posterior vitreous detachment or vitreous hemorrhage. Just remember that normal ultrasonography is not an exclusion. So in cases of central retinal artery occlusion or occipital stroke, other vascular causes, the signs will be normal. Ocular ultrasound could be normal or even subtle, very, very subtle signs. And you are sure you are not going to use your point-of-care ultrasound if you are suspecting a traumatic rupture globe. So this ends our first case. Let's jump into our second one. And here is the clue. 28 years old male patient presenting to you ED following a high-speed motor vehicle accident with low GCS or depressed conscious level. So this is the details. He is 28 years old, following a high-speed motorcycle accident. Her GCS is 5. Her BB is low, 88 over 54, with tachycardia, with heart rate 120. There is clear evidence of unequal pupils, with the right side being more dilated, sluggish in reactivity, 6 millimeter, and sluggish reactivity, while the left pupil is about 3 millimeter and still reactive. And the motor response is extensor, so he has a decorticate posture. So among these findings, what do you think are the most concerning neurological signs? I think if we had that combination of low GCS, unequal pupil, with decorticate posture, with that decerebrate posture following traumatic insult, you will have that concern of expanding hematoma, intraocular pressure, or impending herniation. And for sure, if we have a look over that hemodynamics, the airway will be at risk. Her BB is low with tachycardia, so there could be another source of hemorrhage or other cause explaining that low hemodynamics. But again, I think also that you will agree with me from the neurological point of view, the next step will be doing a CT scan after sure resuscitating your patient. So the technician is telling you that the CT will be ready in 20 minutes because has already one case with contrast exam. So the CT will be ready within 20 minutes. And in your ED, you don't have the availability or the capability of invasive intracranial pressure monitoring. So again, what should be the next step in that diagnostic challenging situation? And I think I'm hearing you all answering that this is the time for point of care ultrasound. And if we get for the neuro point of care ultrasound pillars, that will include 3 main pillars. The first one will be the B-mode cranial ultrasound. That will be a little bit less important, but again, it will give us some idea about the midline structure shift. But if I'm going to use or focus on 2 main exams in this interaction session, I will choose using the optic nerve sheath diameter and the transcranial color-coded Doppler, and we are going to discuss these particular 2 exams in our session. So again, let's jump directly over a brief summary how to get the scan. For the optic nerve sheath diameter, we are going to use the same principle that we have explained in the previous case. We are going to use our high-frequency linear probe, transverse and longitudinally over the globe while the eye closed, and transparent dressing if available, with copious amount of gel, avoiding any direct pressure of the globe. While for transcranial Doppler examination, we are going to use the phased array probe. It will be in transverse situation, transverse position, with the marker pointing toward the patient eye, while the patient will be in sitting supine position, in the supine position with the head elevated about 20 or 30 degrees. And we are going to put our probe just immediately above the zygomatic arch in front of the tragus and trying to find a good acoustic window. So as we explained already in the previous session, how to get our ocular exam, this is the optic nerve sheath diameter. And again, this is the globe, this is the posterior segment, and this is the retina, and from here come the optic nerve. So as we know, we are going to measure the optic nerve sheath diameter about 3 millimeter back to the retina, and at that distance, we are going to get from the outer to outer dimension. So the right optic nerve sheath diameter is 6.8, while in the left side, it's about 6.5 millimeter. So in both eyes, it's greater than 6. So let's keep in mind that findings, and we'll combine this finding with other finding we are going to get with the transcranial Doppler of the middle cerebral artery. So here, this is the scanning technique for the middle cerebral artery using the transcranial Doppler. Again, just to remind you, and we are going to use the phased array probe. The marker will be to the patient eye. And we are going to put our probe just above the zygomatic arch in front of the tragus and trying to locate a better acoustic window. And the first thing we are looking for here is the midbrain. So this apple-shaped structure I am encircling with my laser now. This is the apple-shaped structure here in the middle of the image is the midbrain. And this is a very important anatomical landmark because as we know from our anatomy, this is the site for the basal cistern. And this is the basal cistern. We can locate our circle of Wells, and for sure one of these main arteries forming the circle of Wells will be the middle cerebral artery. So after getting this anatomical landmark of the midbrain, we are going to apply our color flow Doppler using locating or trying to locate the main arteries forming the circle of Wells. And for sure this will be the middle cerebral artery on either side, and this one it will be the anterior cerebral artery moving toward anteriorly, and this the posterior one will be the posterior cerebral artery. And as we know from color flow phenomena, if the flow is toward the probe, it will be red, but if the flow is away from the flow is away from the probe, it will be blue in color. So this is the middle cerebral artery, the ipsilateral to the probe, so it appears red. So after getting a good view for the middle cerebral artery, we will apply the pulsed wave Doppler. So back to our patient, we applied already the pulsed wave Doppler, and here is the finding that we find. This is the waves that we can trace from our patient. This is the peak systolic velocity, it's something 100 something. This is the end systolic velocity, it's about 18 centimeter per second. And here the main flow velocity is about 51 and pulsatility index 1.8. So again, these measures are here on the left side: peak systolic, end diastolic velocity, mean flow velocity, and pulsatility index 1.8. So if you can remember that previously we have that optic nerve sheath diameter, it's about 6.8 on the right side, 6.3 as I remember in the left side. So in either side it's greater than 6. And if we add these findings to these findings from transcranial color-coded Doppler of the middle cerebral artery, my question will be, according to the Brussels iconic criteria, which brain point of care ultrasound findings increases the suspicion of elevated intracranial pressure? So we are going to discuss this P-iconic criteria in a minute, but if you have like a gestalt about these criteria, what are the most likely point of care ultrasound that suggest high intracranial pressure? Which of the following combination is optic nerve sheath diameter 4.8 plus pulsatility index 0.9, or the second option, optic nerve sheath diameter 6.5 plus pulsatility index 1.9 and end diastolic velocity 18, or optic nerve sheath diameter 5.2 with end diastolic velocity 30 or pulsatility index 0.8 only? So which of the following combination would you suggest is more favorable for the diagnosis of high intracranial pressure? So I'm assuming now you are answering. So let's go for the answers. And again, 100% of you suggested that the combination of high optic nerve sheath diameter, high pulsatility index, and low end diastolic volume suggest non-invasively the presence of high intracranial pressure. And again, this is completely true, and I'm going to go through rapidly through this article that represent an expert consensus that published in 2025. This is the Brussels consensus for non-invasive intracranial pressure monitoring when invasive systems are not available, and it's mnemonic like P-iconic. And it included about 41 experts from neurocritical care, neurosurgeon, critical care, and emergency physicians. And this is the summary for these criteria. So if you don't have like an invasive monitoring for intracranial pressure, they are recommending a multimodal approach, integrating both clinical examination, brain CT findings, and number 3 and number 4 here are 2 point of care ultrasound findings, and the last one will be like a bedside clinical, which is the automatic pupillarimetry measuring what's named as a neurological pupillary index. So I'm going to focus number 3 and number 4 here categories. The first one is the optic nerve sheath diameter, and the second one is the transcranial color-coded Doppler for the middle cerebral artery. And they are suggesting using 3 cutoff points to get a clue for high intracranial pressure. The first one is the optic nerve sheath diameter greater than 6 millimeter mercury. The second one is pulsatility index greater than 1.3, and the last one will be end diastolic velocity less than 20 centimeter per second. So I will go rapidly through what the meaning of the pulsatility index and end diastolic flow or end diastolic velocity. When applying our transcranial color Doppler and pulsed wave over the middle cerebral artery, you will get this wave. Normally, the normal morphology for this wave will be a systolic peak, and then will be a diastolic, not low. So the diastolic flow will be a little bit high, or a little bit comparable to the systolic velocity all over through the whole cycle. While in this condition, when the intracranial pressure is high, this means it's going to squeeze more and more the cerebrovascular structure of our brain, that causing cerebrovascular resistance. And the first stage that's going to be affected during the cycle will be the diastolic. So our diastolic velocity will be a little bit lower. And this means if the diastolic velocity is low and the systolic is not affected, this means that our denominator here will be high, and this means our pulsatility index will be high. So pulsatility index is like an indirect surrogate marker for the intracranial pressure, and this is the interpretation. Normally, it's ranging between 0.6 to 1.1. So in something between 1.2, 1.3 will be interpreted as mildly increased, while the significant increase and significant cutoff points that have been included in the P-iconic criteria will be pulsatility index greater than 1.3. But please take care that pulsatility index is not sole, or is not only affected by the intracranial pressure. It could reflect also other conditions like cerebral vasospasm, arterial obstruction, low cardiac output condition, advancing age with arterial stiffness, or even the effect of carbon dioxide level over the cerebral vasculature. So it should be interpreted in the clinical context, and as P-iconic criteria recommended, it's better to be a multimodal approach, integrating clinical CT findings and 3 point-of-care ultrasound measures, which are the pulsatility index greater than 1.3, end diastolic velocity lower than 20, and again optic nerve sheath diameter greater than 6 millimeter. So back to our patient, if you have that clinical findings and you have that very, very strong clinical suspicion of intracranial pressure, for sure, you are going to follow the Brain Trauma Foundation guidelines, optimizing the oxygenation, posting the perfusion, maintaining normocapnia, and avoiding routine hyperventilation, getting the head a little bit elevated 30 degrees, and planning for urgent and or emergent CT imaging, and considering even hyperosmolar therapy or hyperosmolar treatment like mannitol or other dehydrating agent, and for sure emergent neurological condition. And trending is very important. Trending for the point of care ultrasound could be more important than the crude vessels or the crude figures or the crude numbers at the first time. So again, if you are still waiting for the CT and you have the time and you notice the patient is getting more and more worse neurological condition, again, repeating that parameter will be clinically relevant. After the CT, we can see here that we have a right subdural hemorrhage with clearly evident midline shift, coinciding with the finding that we find with the point of care ultrasound. So to sum up, the point of care brain ultrasound is a complementary, but it's not replacing the gold standard CT or invasive intracranial pressure monitoring. It should be like a combined or integrated multimodal. So optic nerve sheath diameter will give you a clue about the structural intracranial pressure surrogate, while the transcranial Doppler will give us a clue about the physiological cerebral blood flow. And again, remember that P-iconic integration criteria. Trending could be, again, more important than the crude or the initial number themselves. Again, next time you are going to use point of care ultrasound, think multimodal. There is no single one measure or single one modality that will give you the clue or the answer. This will end our session today, and after our first session about the ocular and point of care and neuro point of care ultrasound. And sure, for any question, I will be happy to get by the end of the session, inshallah. Thank you, everyone.
Thank you, Dr. Muhammad, for this interesting topic, very important. If anyone has any question, please write in question and answer. Actually, I can see one question. Phased array, do you mean the cardiac probe? Dr. Muhammad, this question, phased array, yes, I think, is the echo probe, yes.
Yes, Dr. Haitham. Phased array will be the cardiac. From the phased array probe, if it's available, we can use the TCD mode, transcranial Doppler mode.
Yes. Please write if any other question, and we'll go to next speaker until you write your questions. So Dr. Wissam, can you introduce our next speaker, please?
Welcome, Dr. Sayuri Enrique, Emergency Medicine and Disaster Medicine Specialist from Lima, Peru. She is ultrasound fellowship granted from Highland Hospital de Mayo Hospital, attending physician at Carlos Lanfranco Laos Hospital, attending physician Clinica International Susan Borja, attending physician San Juan do Ligranco Hospital. The floor is you, Dr. Sayuri, with a nice lecture about venous thrombosis.
Okay, good evening, everyone. It's an honor to share this session with such as a distinguished speaker. Okay, so today I will present a case demonstrating how multi-organ point of care ultrasound helped us identify the brain thrombosis as the source of an acute pulmonary embolism and change our clinical decision making. Okay, beyond the basic multi-organ focus in acute pulmonary embolism. So, a clinical case. A 43-year-old woman presented to the emergency department with sudden onset shortness of breath, right slight pleurotic chest pain, dizziness, and near syncope. She had undergone new arthroscopy 2 weeks earlier and was taking combined oral contraceptives. She had no previous cardiopulmonary disease. Okay, initial assessment. Her vital signals were heart rate 126 beats per minute, blood pressure 102 over 66 millimeters of mercury, respiratory rate 30 breaths per minute, oxygen saturation 88% on room air. On physical examination, she was tachypneic, her lungs were clear on auscultation, and she had mild swelling on her left calf. Okay, in this pulmonary was one of our leading different diagnostic. So what will be your next step? A chest X-ray, maybe B, CT pulmonary angiography, C, multi-organ focus, D, start antibiotics. I read in the chat. Okay, continue. The answer is multi-organ focus. Why multi-organ focus? Okay. Let me see. Cardio focus. What are we looking for? Oh, sorry. What are we looking for? Right ventricular size, RV systolic function, interventricular septum, inferior vena cava, pericardial function. So is what we're looking for. But what did we find this patient? Findings, okay. Dilated right ventricle, right ventricular, left ventricular radio, MAR1, flattening of the interventricular septum, the D-SIG, dilated IVC with minimal respiratory collapsing and reduced depth. Which cardiac focus finding in most suggestive of acute right ventricular pressure overload? Pericardial fusion, design, left ventricular hypertrophy, or mitral regurgitation. In this imaging, we see the same things. Is the correct answer? The B. Okay. TAPSE. What does mean TAPSE? TAPSE is another important parameter was TAPSE, or tricuspid annular plane systolic excursion. TAPSE measures the longitudinal systolic function of the right ventricular using M mode in the apical four-chamber view. The normal value is 70 millimeter of grade, but in our patient, finding in our patient TAPSE 13.7. Reduced right ventricular systolic function, acute right ventricular pressure overload. So the case is the middle, 13.7. Also, TAPSE alone is no diagnostic of pulmonary embolism, together with right ventricular dilatation, and these things that increases our diagnostic of confidence. So what is the other point? What will you see? McConnell sign. What are we looking for? Regional right ventricular wall motion. What did we find? Akinesia of the mid-free wall. Preserve apical contraction. Why is important? It's important because it's just a step of acute pulmonary embolism, indicates acute right ventricular dysfunction, but it's not diagnostic, but it's okay. In this imagine, I will see that site McConnell. McConnell sign, the diagnostic when the consisted of hypokinesia of the mid-free wall of the right ventricular with preserved apical contractibility. Okay, so we need to see lung ultrasound. What are we looking for? Because we need to discard other pathology: pneumothorax, pulmonary edema, pneumonia, peripheral pulmonary infarction, or pleural effusion. But what did we find in this patient? Bilateral eye lines, normal lung sliding, no diffuse V lines, no pleural effusion. Okay, or lung ultrasound demonstrate normal lung sliding and bilateral eyes. There were no diffuse V line, no pleural effusion, and no evidence of pneumonia or pneumothorax. This examination helped us exclude alternative causes of acute dyspnea, because one of the symptoms is dyspnea for this patient, in patient who suspicious of embolia pulmonary. So what is the other? Compression ultrasound. What are we looking for? Compressibility of common femoral vein, popliteal vein. So we need to see the compressibility of the vein. So compression ultrasound demonstrated a no compressive left common femoral vein with a visible intraluminous thrombus. In our patient, what we found? Left common femoral vein did not collapse with compression. Visible intraluminal thrombus y acute proximal divitude. And why this is important? Most pulmonary embolia originate from proximal lower limb DVT, On this examination, identify the probable source of the embolism. So that here, when I see there's no compression of the vein, maybe we can see a DVT in the under compression, no? So which focus finding most strongly support pulmonary embolism this patient? Dilatate inferior vena cava disease, proximal deep vein thrombosis, or McConnell-6. The correct answer is proximal deep vein thrombosis. Why? No individual ultrasound finding confirms pulmonary involvement. However, identifying a proximal DVT together with right ventricular strain dramatically increase the probability of acute pulmonary embolism. In this patient, we have had as female, and we have had antecedents of she had or she take ICOD, no, she take pills. So it's very important for the antecedents. In an inferior vena cava, what are we looking for? IVC diameter, the respiratory variation. What did we find? Dilatate the IVC, minimal inspiratory collapse. Why is important? These findings suggest elevated right pressure, right ventricular overload. They support the diagnostic, but are not diagnostic of pulmonary embolism. Okay, you can see. Dilatate, right? Inferior vena cava is very dilatate in this patient. What will be your next step? Maybe repeat is ECG or CT pulmonary angiography, discharge the patient, bronchoscopy. The correct answer is CT pulmonary angiography. The CT pulmonary angiography confirmed bilateral pulmonary emboli involving both pulmonary arteries in this patient. Also, focus strongly increase our diagnostic confidence. CT pulmonary angiography reminding the gold standard to confirm a diagnostic. For example, in my country, we don't have in any hospital CT pulmonary angiography, but I know what the ultrasound is the diagnostic, but because the clinic maybe with all results in focus, we diagnostic or EP only for ultrasound. For example, CT pulmonary angiography in this patient bilateral pulmonary emboli, right ventricular strain, diagnosis was confirmed. No, what treatment should be started promptly in this hemodynamical stable patient with confirmed PE? Antibiotics, anticoagulation, corticoids, diuretics. Well, we know anticoagulation. Okay. So the patient received oxygen therapy and immediate anticoagulation. She remained in hemodynamical stable, so systematic thrombolysis was not indicated in this case. So pulmonary embolism should always be considered in patients with unexplained dyspnea and risk factors. So multi-organ focus rapidly increase diagnostic confidence. For example, in my case, in my country, no, we don't have in any hospital tomographer or TC, but we use ultrasound. But it's very important for us to use a focus exam. So multi-organ integration is very important in some case. So we don't have CT. So in focus exam here, finding reveal dilatation, disease, reduced TAPSE, and lung and lines, no edema, possible peripheral infarct, and leg veins, no compressible femoral vein, and ABC dilated with port collapse. Okay, in conclusion, in this case, demonstrate that not single ultrasound finding established the diagnostic, intersects the integration of cardio, lung, and venous ultrasound, change our clinical reasoning, and allowed early diagnostic and treatment. Okay, but POCUS did not replace the clinical judgment. Thank you very much for attention.
Molto gracias, dear Dr. Sayori, for this nice lecture. Also, I will
I'm
look for
sorry
a
for
chat if you have a questions. But let me ask
please.
you a question. From your experience in Peru, how ultrasound for DVT and pulmonary embolism help you in pick up a rapid diagnosis and solve a problem for patients? So you can talk like a little bit about your training and about your experience in Peru in dealing with such case as an emergency medicine physician, not as a cardiologist, just to explain that to our audience and to help them know much about point of
Okay,
care ultrasound. Okay, go on.
okay. I will try to speak slowly. Okay, but when I said, in my country, we have a problems with the imaging, for example, for the CT tomography. Okay, so
Yes.
in uh, a lot of number of hospital, we have a ultrasound only convexo and some in cardiac.
Okay.
So it's very important for no, okay, for near 13 horas. Some hospital we have a station bus. And so
Mm.
when I worked in Cayetano Hospital near a Fiori. Fiori is a station bus. So people who traveled for 18 hours. So with this history, we know what is the possible diagnostic, because we have a patient in cardiac
Okay.
paro respiratorio. Okay, so woman maybe the 40 50 age.
Mm.
So who in the clinic we see the no thrombosis but venous insufficiencia venosa in the examine in the legs. So I don't know how to say
Okay, take your time. We just listening to you.
okay, so in the clinic, so it's we are for how do I say what it's give me por el hecho de ser mujer, simple for being a woman, we suspect about tape. So in the first, as I
Okay.
see, okay, I will see I will see the femoral vein.
Okay.
So it's different, depends the kind of patient in who enter in our emergency. So the 2 months ago, a woman who traveled to 20 hours go to the emergency, arrive to the emergency, but in paro cardíaco. So it's a woman to 82 years who arrived or who go to Lima, for to celebrate on Mother's Days. So very, 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 very sad, because I can help her. I put the ultrasound. I saw the ventricular dilatate. But in this case, so very suspicious for only for being woman. The first zone when I will see is the femoral.
Yeah,
Just
just to explain to our audience, it is like a old age female coming in a bus with a long travel over 20 hours, and it come to the hospital as a cardiac arrest. They put ultrasound and diagnosed by found a thrombus in the femoral vein. Then they follow it up to found a pulmonary embolism as the main cause of cardiac arrest. Let me ask you last questions. You have a
Doctor,
well-developed fellowship
sorry,
in Piro for a point of care ultrasound. How long does it take for this fellowship, and when did it establish?
okay. Sorry, Dr. Hussein, before answering, after
Mm,
answering this question, Dr. Grace is back with us, so she
excellent.
can.
Okay.
Yes, so can we introduce Dr. Grace, please, Dr. Hussein?
Dr.
Yes.
Grace Wanjiko is my colleague and my friend. She is Associate Professor of Emergency Medicine, Division of Global Emergency Medicine at Albert Brown Medical School. She spent 2 years fellowship in acute and critical care ultrasound was Master of Public Health in Global Health at Yale University. She is a well-known speaker in a research interest and the creation of point-of-care ultrasound in many countries, such as Kenya. And she lastly was awarded the Global Health Award from the Society of American Academic Emergency Medicine for her contribution for point-of-care ultrasound established in Kenya. The floor is you, Dr. Grace.
Hi, everyone. I'm Dr. Grace Wanjiku. Thank you so much, Dr. Wisam, for your presentation, for your introduction. And so my topic today is OB.GYN. And please stop me at any time if you have any questions. I'm going to just quickly run through some cases, which are not very complex cases, but I just wanted to make sure that we really are covered with the basics. Sorry, so this is, okay. So these are POCUS OB.GYN cases. I just wanted to emphasize that these are from our rural ultrasound trainings program that we have in rural Kenya. So this first case is a 22-year-old female that came in complaining of lower abdominal pain, nausea, vomiting, and the nausea is worse in the morning. And the patient was hypotensive and tachycardic. And so, the clinician who saw them started with the resuscitation. They sent off their blood work, but then they immediately did a pelvic ultrasound. And this is what they found. So I just wanted to point out, just because we are short on time, that this is a sagittal view of the female pelvis. And for your landmark, you have the bladder with this wall here, with a thick wall, with the urine in it. We see the uterus here in its pear shaped appearance, and we see an endometrial stripe in the middle. We have free fluid around it. But when we look in the kind of inside the uterus, there's no intrauterine pregnancy in it. This is the transverse view of the same patient. You see the bladder here. This is all free fluid. You kind of see it's heterogeneous material, and this is the uterus coming in its transverse orientation. So let me just, this is a bladder here that is free fluid. You see kind of the heterogeneous appearance, and this is the uterus. You see the endometrial stripe, and there's no IUP in there. Okay. So once you see that, it is recommended, and we're going to go through why. It is recommended that you do a right upper quadrant ultrasound as well. So you can tell that there's free fluid in the pelvis. And so what this clinician did is that they did an EFAST. So this is the liver here. This is the kidney, and you can see that it is positive for free fluid as well. Okay. So that's the first case. Anyone has any thoughts about what's going on, you can put it in the chat. But clearly, we can agree that we did not see an IUP, and that we saw a lot of free fluid in the pelvis, and we saw free fluid in the right upper quadrant as well here. Okay, so we're going to move on quickly to the next case. This is a 23-year-old female who's coming in fatigued. They're pale, they have vaginal bleeding, they are hypotensive and tachycardic as well. So, we start resuscitating the patient, we send off the blood work, including a pregnancy test. But the recommendation, at least the one that we give, which I would give, is to go ahead and do your ultrasound, a pelvic ultrasound and an EFAST. So this is the pelvic ultrasound as well. They started with a sagittal view. So once again, we can see the uterus is here in its pear shape. The bladder is not very clear, but it's off to the side, and you can see that there's heterogeneous free fluid around it. This is the transverse view. So here the probe marker is facing the patient's right. We do see the uterus here. We don't see anything inside it, and you can agree that there's a lot of heterogeneous material all the way around it. Third case. So these are not obscure cases at all for a reason. 30-year-old female, lower abdominal pain. They say that their last period was last month, but it was just spotting. It wasn't a normal period. They don't think they are pregnant. So this is their ultrasound. We see the bladder here, which is your landmark. You see the uterus, and you can see the endometrial stripe. There's a lot of heterogeneous material around it as well. So this is a sagittal view. Okay. That's the transverse view of the same patient. We see the bladder more anteriorly. It's always good to point out the bladder because it really does help kind of ground you. You see the uterus here, but then there's all of this stuff around. All right. So what is the goal of doing ultrasound in the first trimester? Why do we do it? So the first thing we want to confirm is to check whether there's an IUP, an intrauterine pregnancy. The greatest question we have in the first trimester is that, can we see an IUP, yes or no? That's the biggest question that you have. If you see an IUP, then it's important to establish the gestational age accurately, and then to see if there's multiple gestation. All right. We use the curvilinear probe. This is the orientation for the transabdominal transfer. So you go right above the pubic symphysis. As you can see, this gentleman holding the probe. The probe marker is facing the patient's right. And when you do that, this is what you should see. In the normal case, you see the bladder more anteriorly, like we saw in our patient. You see the uterus kind of more posterior to that. And this is what it should look like. And the goal is to fan in both directions until the uterus disappears in both directions. The next view is a sagittal view. So you are above the pubic symphysis. Now your probe marker is facing the patient's head. These are similar as you would be doing an EFAST. It's just that now your focus is the uterus. So this is very important view. And if you're having a hard time with the transverse view, I would encourage you to actually start with the sagittal view because it really does help anchor you because you see the bladder here. If they have a full bladder, then it acts as a good landmark for you. It also is a good acoustic window to allow you to see the uterus. So here we do see the uterus. It's a bit more clear here because the bladder is forming a good acoustic window. There's a little bit of falling off on the side here. Sometimes putting pressure down helps to see the entire uterus. You see the cervix here and you see the vaginal stripe. And the bladder uterine juxtaposition is a key landmark for you as well. So every time, make sure that you can trace out your bladder and make sure that you can see your uterus juxtaposed with the bladder, because then this really helps to anchor you to know that you're looking at the right thing. So especially when there's a lot of free fluid, it can be chaotic, it can be confusing. So if you see this juxtaposition here, it really does help you know that you're looking at the right thing. Okay, so when you do the two views, so the number one thing we're looking for is to see whether there's an IUP or not. And for us to say that we have an IUP, we need these three things. We need to have a gestational sac, we need a yolk sac, and we need a fetal pole. If you do not have these three things, you cannot declare with confidence that there's an IUP. So in this case, we do have an IUP because there's a gestational sac here. We see a fetal pole, and we see the yolk sac that looks like a Cheerio, a round circle here. So you have everything you need to be able to declare positive for an intrauterine pregnancy. If you see a fetal heart rate inside there, so you can see the flickering back and forth within there, then that confirms that this is a live IUP. So fetal heart rate, you have a live IUP. Okay. I wanted to just make sure that I highlight this as well, because if you see an IUP, you want to have a thick wall of endometrium around it, right? In this case, you can see that this IUP, it's an IUP for sure. Well, you don't see the fetal pole, but you see the yolk sac. Let's say you see a fetal pole, but then the edge from the gestational sac to the edge of the myometrium is less than 5 millimeters, definitely less than 7 millimeters. So this is not an IUP. This is actually an interstitial or corneal ectopic. And this is because the myometrium mantle is reduced. So you can see this IUP is eccentric. It's kind of deep in the wall of the uterus, which makes it an ectopic. So this is very, very important. So when you see what you think is an IUP, make sure you check the walls all the way around it to make sure that they're more than 7 millimeters. Okay, so in the first trimester, we want to say whether we have an IUP, or if you do not see an IUP, then this is what you document. You document that there's no definitive intrauterine pregnancy. It's an ND-IUP. And anytime in the first trimester when you have an ND-IUP, it's either because it's too early for you to see anything. It could be because it's an ectopic pregnancy, or it could be because they're having a spontaneous abortion. So how do you go around figuring this out? Because you don't want to, make the wrong determination. So ectopic pregnancy is a big one for us, right? And as we can all agree, the case series that we had, all those patients came back with positive pregnancy tests, with a lot of free fluid in the pelvis and some with free fluid in the right upper quadrant as well. So ectopic pregnancy is a type of an ND-IUP. And if it is ruptured, then you will see free fluid in the pelvis and a positive beta HCG blood test. So all of these patients, they came in hypotensive, they came in bleeding a lot, and especially if you have blood in the right upper quadrant, these patients need to go to surgery. There's no other management for this. They have to go to theater. I won't last on this because we know these. Most of them are in the fallopian tube, but we do have the corneoectopic that we talked about. We have cervical ectopics as well, which when they rupture, they can actually cause pretty significant bleeding. You can have an ectopic in the abdominal cavity as well. So anytime you see an ND-IUP, right, if it's a positive pregnancy test and the patient is hypotensive, then you're calling GYN, you want them to go to the OR. If you see an ND-IUP and the patient is stable, then the recommendation is that you send them for a formal ultrasound, because then they do want to see where the IUP is located. And this patient, if they have not ruptured, they might be eligible for treatment with methotrexate. We're going to talk about it later. But if they've ruptured, they're going to theater, no question about that. So I wanted to discuss the case of a heterotopic pregnancy, right? Because this is a special case where there's a simultaneous intrauterine and ectopic pregnancy. So this is a rare incidence, right? I think there's a big range of what's documented in terms of the incidence of this. But if a patient is undergoing assisted reproductive technology, then the risk that they have a heterotopic goes up significantly, right? So if you think a patient has a heterotopic, this is a patient who will have an IUP, but if they are unstable, right, and they have free fluid, they could have another IUP somewhere else that has now ruptured. So these are high-risk patients that should be managed, that if you see one IUP, you should not think that you're done. Definitely involve OB/GYN for these high-risk cases. But heterotopics do happen as well. So the reason I wanted to focus on ectopic pregnancy today is that this is a condition. I mean, a lot of times with POCUS, with OB/GYN, people are asking, why do you this is OB/GYN. This should all be managed by OB/GYN. Why do we care as emergency doctors? The first trimester patients belong to us. They come to us first because a lot of them don't even know they're pregnant, right? They come in very unstable, right? So we will be the first point of contact for them. And there is a high incidence globally, right? All over the world, like the statistics I found was from 2019, that 1 to 2% of pregnancies globally presented as ectopics. However, so this is just a global incidence. But when we are working in the ER, remember when we're in the ED, we self-select, right, for the unstable patients. So the incidence of patients with concerning signs who come in with vaginal bleeding, abdominal pain, who end up having ectopic is pretty high, right? So any woman of childbearing age who comes in with abdominal pain, who comes in because they're syncopized, who comes in because they're bleeding, they are hypotensive, they have an ectopic until you prove it otherwise, right? The incidence for us in the emergency department is much higher than people who are in the outpatient world, or people who work in other non-critical, non-acute settings. So this is the leading cause of pregnancy-related death in the first trimester. So we own this condition. We really should be good at being able to diagnose, manage it, and get these patients to OB/GYN in a timely fashion. All right. So the classic triad of abdominal pain, amenorrhea, vaginal bleeding only occurs in 25% of patients, right? So most of the patients will come with very non-specific symptoms. They have nausea, vomiting, they're dizziness, they syncopize. So anytime you're dealing with a woman, make sure you send off, all the blood work, you resuscitate them, but get that probe as early as possible onto their abdomen to figure out what's going on, right? And if they've ruptured, they're coming in hypotensive, tachycardic, peritonitic as well. So I think we've talked about that, right? If a woman presents like this is a ruptured ectopic until you prove it otherwise. As soon as possible, do a pelvic ultrasound and do an EFAST, right? So studies have shown that doing ultrasound as early as possible decreases length of stay by an average of 70 minutes, right? So these patients leave the ER if they need to go to surgery, they go sooner, decrease time to operative intervention by 90 minutes. They decrease the likelihood of a patient having an ectopic, being sent home by mistake, and then coming back with a ruptured ectopic. So getting patients to surgery earlier is our goal, because this is how we can save lives. Right. So the utility of POCUS in this field is that when you see an IUP, right, in a patient, you rule out an ectopic in the majority of the patients, right? Just because we said heterotopics are rare. So if you look with your ultrasound and you see an IUP there, this is very reassuring, right? Unless it's a heterotopic, and this is very rare. If the patient is stable, definitely talk to OB/GYN and then send them for a comprehensive ultrasound. They can leave your department and they can go to radiology to get a comprehensive ultrasound. So I just wanted to speak about beta HCG testing, right? Because you do your ultrasound. I tell people, do not wait for the beta HCG. Do your ultrasound and see what's going on. Get an idea early on. But the beta HCG discriminatory zone is a serum HCG level above which ultrasound is expected to show you a viable IUP. And the numbers are this. So if the beta HCG is 6,000 or more, if you do a transabdominal ultrasound, you should be able to see an IUP. And if you do a transvaginal at a beta HCG of 1,500, you should be able to see an IUP, right? But this is in a normal, viable pregnancy, right? However, an ectopic pregnancy is not a normal pregnancy. It's a failed pregnancy, it's a failed IUP. And so an ectopic can present at any beta HCG level, right? And I wanted to highlight this because if you have a patient who's unstable, does not have an IUP, and they have a beta HCG of 500 and they have free fluid, they could have a big enough ectopic that has ruptured and caused this. This is not the case of an early pregnancy. This is not a patient you say, oh, the beta HCG is low, and so I should not be able to see anything. I hope this makes sense, because an ectopic pregnancy is failed, and so the beta HCG does not double as it would in a viable IUP. I hope that makes sense. So don't let the beta HCG throw you off. And let me know if you have any questions about this. I really want to focus on that. So always do your POCUS, always, always. Because when you make the call to OB/GYN, that has happened to me. People will tell me, oh, that beta HCG is too low. The patient cannot have an ectopic that's big enough to have ruptured. But if they have free fluid, they are unstable. Does not matter what the beta HCG is. They need to go to theater. Okay. If the patient is not ruptured, obviously you don't see an IUP, positive pregnancy test, the patient can go for a formal ultrasound. If they find an an ectopic implanted somewhere, then you're calling OB/GYN, because then they would look at the indications and contraindications of treating this patient with methotrexate, right? So unstable patient go to theater. Stable patients can be treated with methotrexate. And this was in the lecture that I did before, but we have indications or contraindications. So together with GYN, you will decide this patient can be treated with methotrexate and they're going to follow up in clinic. Right. There's some published protocols that are out there. So send off basic labs, and then these people follow up in clinic. So like they're not going to follow up with us. They're following up with GYN, who checks their HCG levels on day 1, 4, and 7. And this should decline 15 to 25% by day number 7 and should go to 0 by 2 months. There are different protocols for methotrexate. There's a single dose, there's a 2-dose regimen, and there's a multi-dose regimen. So this just depends on the practice where you work. So whatever GYN recommends, because they're the ones who are going to follow them up, then we just do that and discharge the patient. Okay. So I don't know how we're doing in terms of time, but I really just wanted to kind of focus on first trimester and ectopic pregnancy. Are there any questions at this time?
Not so far.
Okay. And if people have questions about the other aspects that we did not cover, I'm happy to take those questions as well. Because we have second and third trimester, or people have other specific questions, I'll take those. So I'm going to stop the share for now.
Some of people may be around for watching the match between Argentina and UK.
Has it started?
Not
And
yet.
we're really in trouble. We're competing with.
In 30 minutes. Yeah.
Okay.
So have you finished, Dr. Grace?
Yes, I'm done.
So thank you very much. Dr. Wissam and Dr. Haytham, if you want to say something or you have a question to Dr. Grace or Dr. Nasruddin.
We don't have any question in the chat, but we thank Dr. Grace, thank Dr. Nasr, and thank Dr. Sayori for this nice talks.
So yeah, I would like to thank all of you for this very, very interesting, very informative webinar. Really appreciate it. I personally enjoyed them very, very well. There was a question to Dr. Nasruddin, if there is any race difference in the optic nerve sheath diameter between races, like in white, black, or Asian differences.
Yes, Dr. Ashraf. Already, I have two questions. The first one was about the diagnostic performance of transcranial Doppler for the diagnosing of high intracranial pressure, and uploaded like one link for meta-analysis study discussing that. It's about it's high sensitivity, but a little bit lower specificity, so it's higher sensitive than being specific. So I'd like to think it like a D-dimer. So if it's negative, it's going to rule out. But if it's positive, you should think about other differential diagnosis. That also I have highlighted the other factors that could affect that pulsatility index and diastolic flow and others, cerebral dynamics and waveform. Again, it's not about one parameter. We should integrate all together. It's multimodal. We should integrate clinical to CT and point of care ultrasound findings. And again, point of care is not a replacement, but it's complementary to other diagnostic modalities, in particular in the presence of like logistic constraints. This regarding the first one. For the second one about the again, if there is any racial or ethnic variabilities regarding the optic nerve sheath diameter. So the normal value or the normal cutoff point for optic nerve sheath diameter remains very controversial, and there is many systematic reviews and meta-analysis trying to find a true cutoff point. But I also shared one link for one recent systematic review meta-analysis showing no significant subgroup differences between different ethnic values. And again, using cutoff point greater than 6 millimeter, in particular 3 millimeters below. And the most important thing is about the way where we are going to get our measurement. So it should be the most consistent site is 3 millimeters behind the retina, and this is the most consistent site for measuring. And again, get outer to outer diameter. So a cutoff point greater than 6 will cover most of the subgroups. And the second thing is, again, combining or integrating this measurement with other point of care ultrasound measurement. And lastly, trending. So not getting one measure and go away, but if you are going to depend on it, it's better to follow up. So I hope I answered it.
From the study we published recently, Dr. Muhammad Nasruddin, we found when we compared the optic nerve sheath diameter to the invasive ICP monitoring and the CT finding of high ICP, we found that the more they cut off around 0.57 centimeter or 5.7 millimeter, the more it reached up to 100% sensitive. So in our study, it was in traumatic brain injury. As I said, we compared the ICP, invasive monitoring, and CT with optic nerve sheath diameter. And the more it goes above 0.6, the more specific it was. So I totally agree with you that there should be bilateral measurement, more than one measurement. So we take in every side 3 readings, and we take the average of the readings and take it on the other side as well. And then the trend, yes, totally agree. And it's a very, very, very helpful tool at bedside, as you mentioned clearly, Dr. Muhammad. Thank you very much. I think we have to conclude here. Or what do you think, Wissam? Should we
Yeah,
conclude?
I think like from today we learned like many subjects about the importance of point of care ultrasound, and also across the globe how the expert raised from Africa, Asia, America, and South America. So we learned much, and we thank all our eminent speaker for this nice day.
Very thankful to Dr. Sayuri from Bureau. Very happy to see you today, Dr. Grace. I'm always pleased to meet you and learn from you. Thank you very much. And we thank Dr. Muhammad Nasruddin. Very interesting presentation. I enjoyed your presentation, Dr. Nasruddin. And thankful to Haitham and ICOM team, Ala and Habiba. Of course, we should thank WICCEM for having the umbrella of all these meetings and live webinars. Thank you, of course, to everyone attended today, and enjoy the match. See you in the next patch of ultrasound. Thank you very much.
Thank you, Dr. Ashraf. Thank you, everyone.
Bye-bye.
Bye.
Thank you.